So what does the health systems research teach us? And I want to walk you through some of the evidence-based medicine for these. And some of these, for those that are either taking internal medicine boards, geriatric boards, or renewing those board certification, it's best to know what these following studies have accomplished, because they are likely to show up as a board review question. So by name, in the left-hand column are these models of care. And then we've indicated what the goals of intervention are, what the key elements of the intervention might be, and then what the actual outcomes were. So this first one is a care transition intervention, which was trying to decrease rehospitalization rates. And fundamentally what they did is they assigned a transition coach, did a home visit, and they included follow-up calls. A lot of these projects had follow-up calls. And they found that there was a slight reduction in 180-day rehospitalization, not so much of an impact on the 30-day rehospitalization, which, of course, is the time zone with which hospitals get penalized currently. But it does hold promise for that more extended reduction in hospitalization rates. Project RED, the re-engineered discharge, kind of a cute name, also looked at decreased hospitalizations after the first hospitalization, and they had a ramped up discharge plan, better education, and then they had a formal medication reconciliation process by the pharmacist, contacted the primary care provider, and had a follow-up call. That also had a 30-day reduction in acute care use, as reflected by lower emergency room and rehospitalization. The transitional care model, again, looking at rehospitalization. Here they incorporated geriatric assessment, so CGA. And then the post-discharge was similar to the other interventions, which included a transition coach with education. And they had good results showing both 30 and 90-day rehospitalizations decreased. And of course, those are associated with decreased costs. Guided care, you might see this. This is a fairly well-regarded study. Its overall plan was to reduce acute care. And on pre-discharge for the hospitalized patient, they also included medication reconciliation, some formalized patient education. And upon discharge, they had a primary care communication follow-up. They included a hotline, which had, I just say the hotline is probably not the biggest impact that this intervention had, but they importantly had a home visit. And so their results also show that there was less acute care, although it was a modest effect. The program called Interact looked at rehospitalization rates, and it was basically focused on nursing home patients. And in this case, you can see that the key interventions were the use of clinical care pathways, as well as making sure that the advanced care planning was done. And they also found that for nursing home patients that they were able to put a dent in the 30-day rehospitalization rate. The DEED program, so this is focused on emergency room services and recidivism. The pre-discharge comprehensive geriatric assessment was applied here. There was enhanced PCP, or primary care communication, and there was more extensive use of community services. And they found there that there was a short-term rehospitalization reduction. There was a reduction in use of the emergency room, and importantly, better physical and cognitive functionality. This JETI-WISE program looked at recidivism, and basically it was very simple. It was a nurse evaluation and an enhancement of care through community resources. Excuse me. And here they found that there also was a reduction in hospital rehospitalization rates. The GRACE program, here's another important milestone program. The idea here was to look at frail, socioeconomically under-resourced individuals, and the program was to reduce acute care use as well as nursing home usage. And they found that there was home-based care by a team of nurse practitioner and social worker. They included the primary care provider as well as the geriatric team in a co-management model format, and they had specific care protocols for the nurse practitioner and social worker that were doing the home visit. And they found that this program primarily improved patient satisfaction, made a small dent in the 30-day rehospitalization. I'm not quite sure that the cost of the program really merited matched its merits, but it did decrease nursing home admission. So in terms of a accountable care organization format, this might be a good program to implement. The bridge model, again, rehospitalization. Here they used a more social worker based assessment and follow-up for hospitalization, and there was a modest impact on the reduction of rehospitalization. At the bottom here, I want to just point out age-friendly interventions, which is somewhat of a new entity within the healthcare system. This is sponsored by the Institute for Healthcare Improvement and the Hartford Foundation. And the bottom line is that you apply the geriatric 4 M's at each patient encounter. And again, the 4 M's are the what matters: medication, mobility, and mentation. And just pretty much hot off the press, Rush Medical Center discovered that they were able to reduce hospital length of stay by 0.7 days, which is just nearly 1 full day. And the hospital administration is just all smiles about this. So it's tremendous cost savings for this, and it reduces acute care utilization. Here in North Dakota, at Sanford Fargo, our clinic, which is a geriatric forward patient-centered medical home with a monthly audit, found that they had reduced hospital recidivism from 9 to 3%, which is pretty significant. So just to summarize, the geriatric models of care, we know that the acute care for elderly units are effective. They provide good quality transitions because they are a geriatrician-based inpatient unit with a interdisciplinary team. Basically, the team-based care, anything that incorporated comprehensive geriatric assessment or team-based care, was superior to individual nurse or teams of nurse social workers alone. So I really think the take-home message there is that you do need geriatric expertise to optimize the transition for these frail older adults. Now, mind you, all these programs targeted frail older adults. They didn't necessarily address all older adults, right? So there's different levels of functionality. So if you target somebody that's a frequent has frequent hospitalizations, or somebody that has deficits in activities of daily living prior to coming into the hospital, those are the patients that are most likely to benefit from the geriatric intervention. So that leads to the third point, which either geriatric co-management or comprehensive geriatric assessment are strong adjuvants for enhancing transitions of care. Whereas inclusion of home visits, enhanced education, transition coaches, and hotlines all had very modest effects, but overall they were favorable. So we know that the federal government has an invested interest, right, in Medicare to try to improve transitions of care because of all the costs. We talked about, how much money it costs, Medicare. And a few years back, the Medicare introduced a transitional care management payment codes And then, so that's the positive end of, so that's the carrot, from the carrot and stick phenomenon. And then the stick part of it includes the penalties that are accrued that if you have a rehospitalization rate that's above the regional average in your particular Medicare catchment. So some of the things that we can summarize in terms of best transitional care practices is to identify factors that make the transition more complex. Those include things like whether you know if the patient has some form of cognitive impairment or not. So it turns out that 80% of primary care doctors have no idea that their patient has some form of cognitive impairment based upon a national survey. So if you don't ask, you won't know. Also, it's important to engage community health workers, particularly communicating, like, having a physician communication with the home care agency to call up. I would like to talk to the nurse assigned to Mrs. Jones, who I just discharged from the hospital. That could either come from the primary care provider or the hospitalist. It's also important to build contingency plans. Well, we'll give you a trial at this venue. If that doesn't work out, then we need to consider this venue. Also consider rehospitalization risk indices. So that somebody's going to be a recidivist if they have high age, high multiple, high medical complexity, and a history of rehospitalization and dementia. So finally, better use of palliative care, if not hospice care, I think is an important conduit. So just want to mention in terms of even addressing what matters. So one hospital study found that just by implementing a advanced care consultation service, that they were able to reduce future intensive care unit admissions by over 80%. So that was pretty impactful. Just want to mention the skilled nursing facility black hole. A lot of times the primary care provider will not know the patient who's admitted, so it's a newbie for that provider, and so it's a lot of catch up, and it's possible that particularly if the patient's discharged with subacute delirium, it's even worse because you can't get information or good history from the newly admitted resident. The other issues are that the primary care provider will lack information on the care received from the hospital, so there may not be a rapid turnaround on the discharge note. Probably more egregiously is if the nursing home doctor does not have access to the electronic medical record, although that's starting to be solved now with the shared electronic medical record platforms now. The other problem is that there's no medication reconciliation, and I can tell you, for example, that in my clinic, that the medications that were listed in our outpatient may not be the same ones that are listed in the hospital, and I can tell you they're really not the same as they are in the nursing home list. So just dealing with that medication reconciliation is just a whale of a job. And then there's the issue of once the patient, for instance, leaves the nursing home, is that those gains in rehab are quickly lost at home because they're not doing their rehab therapy. So let's just talk about the different models of care in terms of the discharge venues. I think probably the most beneficial of all the options are the home-based care. As a provider, you need to certify that the patient has a homebound status and that they have a skilled nursing need, whether that be nursing, including diabetic teaching, physical therapy, and speech therapy. They will also have potential options for occupational, social work, and home health aides, which are key. And that's particularly, as you can see in the photograph here, you might have a home health aide assisting an individual with transfer from the washroom. The discharge venues include skilled nursing facilities, and here you have to certify that the individual, if they're Medicare, and if they have Medicare Part A, right? So not everybody has Medicare Part A, but if they do, Medicare Part A allows for 100 days of skilled nursing care if you've been in the hospital for 3 consecutive nights, and that you have a skilled nursing need such as intravenous therapy, nutrition, artificial nutrition, complex wound care, ostomy care, or extensive rehabilitation. Now, the problem right now is that you get 20 days totally covered by Medicare, and then on the 21st day, it starts a copay. And so what you have is that there are a lot of older adults who just, aren't progressing as rapidly as you would hope by that 20th day, but then they all of a sudden get these pressures to copay, and while the copay may not be all that crazy, it's 20% copay. There are a lot of people who are don't have a lot of savings, and so they really can't afford that continuation of the nursing home. So they end up getting prematurely discharged from the nursing home, and quite honestly, these are the people that end up bouncing back to the hospital.